Hello, everyone, and welcome to a conversation today about chest x-ray interpretation for the boards. My name is Elaine Cagnina. I did my training largely at the University of Virginia and have been at Brigham and Women's since 2018, where I work largely in the medical ICU at one of our community hospitals, and I'm the Associate Director of the Adult Cystic Fibrosis Program. I have no disclosures. Here's a basic outline of what we will talk about today. We will start by going over basic chest x-ray interpretation and anatomy. Then we will review specific pathologies that are relevant to the boards that are shown here. And at the end, we will review high-yield buzzword diagnoses for the boards and give you some example questions. Before you start to interpret a chest x-ray, it's very important to be sure of what you are looking at. This includes assessing the overall quality of the film, as well as making sure you're oriented to the patient. Before interpreting any film, you should know if you're looking at an AP or a PA film. This is important for many reasons, but notably because the cardiac silhouette will appear larger in AP films. This is why many inpatient films will look like the patient has borderline cardiomegaly. Most films will have an orientation marker, generally on the left, as noted on this film. Occasionally, you will get a film with abnormal orientation, so just be aware. You need to know if the film is over-penetrated or under-penetrated, as that will influence your interpretation. You can generally assess whether the patient is rotated by looking at the position of the clavicle heads in relation to the spine. A rotated patient can appear to have mediastinal abnormalities that are not real. And then, is the patient making a reasonably good inspiratory effort? And finally, is the projection normal? Sometimes, particularly inpatient, the chest x-ray will be shot from the foot of the bed and not head on, which can change what you are looking at. This is an example of why assessing these things first is important. Both of these chest x-rays are markedly abnormal in that they have a left-sided cardiac silhouette. So what are we looking at? I call your attention to the orientation markers, and you can see that the chest x-ray on the left has normal orientation with the right side of the chest on the left side of the film. This is true situs inversus in a patient with primary ciliary dyskinesia. The chest x-ray on the right has an abnormal orientation with the left side of the chest on the left side of the film. The reason for this is that the chest x-ray was shot while the patient was prone. You need to pay attention to orientation in order to be able to interpret these films correctly. So there are many ways to interpret chest x-rays, and there is no single one right way. The important thing is that you have a method to use so that you do it the same way every time, so as not to miss important findings. I will walk you through one method that I like to call the lung parenchyma last method. And the reason for that is that our eyes are automatically drawn in chest x-rays to the lung fields at the expense of all the other important areas on the chest x-ray. And therefore, if you make yourself look at the lung fields last, then you know you will have done a thorough job interpreting it. So I start over here on the periphery of the chest x-ray, looking at the bones and soft tissues first. You want to assess the soft tissues for masses, swelling, and subcutaneous emphysema. Then look at the scapula, clavicles, and ribs to make sure they are symmetric and there are no obvious fractures. Then you move on to the diaphragms and abdomen. The right hemidiaphragm should normally be slightly higher than the left hemidiaphragm. You want to make sure that the diaphragm contours are crisp and that you take note of each costophrenic angle. Make sure to look at the gastric bubble. Make sure there is no free air, and as best as you are able, assess the bowel gas pattern. Next, move to lines, drains, and airways. Here, you are looking at any kind of foreign body. You want to make sure lines and tubes are in good position. Make sure you can identify every foreign body on the film. Now that we've assessed all the peripheral structures, next we move to the central structures. Start with the trachea. Is it midline? Is there tracheal deviation? Is there any marked tracheal narrowing? Then you want to move to the hilum. You should be able to follow the curve of the aortic arch. You want to assess the mediastinum. Are the hyla symmetric? Is the pulmonary vasculature normal or more prominent than it should be? You can then continue down and look at the cardiac silhouette. Are the right and left heart borders clear? Are either of the heart borders obscured by infiltrate? Is the heart normal size? And then after you've assessed all of this, you can finally move on to the lung fields themselves, where you will look for everything listed here and many of the findings we will discuss during this talk. And so we'll start the rest of this talk by looking at a normal chest x-ray. Sometimes we look at so many abnormal films that we forget what normal looks like. A young, healthy, thin person can really look like they have big lungs and a small heart, but this is very normal. Let's talk a little bit about chest x-ray anatomy. As you know, the right lung has 3 lobes, while the left lung has 2. Each lung has a major fissure, shown here in pink, that cannot be well viewed on a PA or AP film because they are obliquely on face. The right lung has a minor fissure, shown here in blue, separating the right upper lobe from the right middle lobe that can be seen on a PA film when there is some abnormality of the fissure. It is often hard to tell exactly which lobe of the lung holds an abnormality on a PA film because there is much overlap. However, pairing it with a lateral view can help. We won't spend too much time on the lateral view today, except to note that it is a useful tool to identify mediastinal structures. The boards will often include a lateral view to highlight these particular topics: mediastinal mass, mediastinal lymphadenopathy, spine sign, pleural effusion, and diaphragm contours. The spine sign refers to the fact that the spine should get darker as you move inferiorly down the x-ray. If it does not and instead becomes whiter or more dense, then this suggests lower lung pathology or infiltrate. So why is it important to know your anatomy? It can help you identify abnormalities. In this chest x-ray, we can see the minor fissure that separates the right upper lobe from the right middle lobe is pulled superiorly, and there is an area of denser tissue medially. This is a classic chest x-ray showing right upper lobe collapse, which can be caused by mucus plugging, an obstructing mass, foreign body, or some other obstructing pathology. Right upper lobe collapse is a common pathology that you should be able to identify on imaging. In this chest x-ray, we can see that the minor fissure is pushed down out of place. This chest x-ray shows a large right upper lobe tumor with bulging minor fissure. In each case, knowing the anatomy helps us localize the abnormality. One final example of why you need to know normal anatomy. In this chest x-ray, we can see that the right hemidiaphragm is markedly elevated compared to the left. I told you the right diaphragm should be higher than the left, but this is abnormally high. This is a film showing right hemidiaphragm paralysis. Whenever you see this much discrepancy between the 2 hemidiaphragms, you should question at least some degree of diaphragmatic dysfunction. Now we will move into some common and specific pathologies that will be tested on the boards, starting with mediastinal and hilar pathology. You will almost certainly have a question about hilar lymphadenopathy. Bilateral, relatively symmetric hilar lymphadenopathy is shown in each of these films, here and here. The board exam loves to test on sarcoid, which we will touch on more later. Other causes of hilar lymphadenopathy include borreliosis, which we will also touch on later, lymphoma, other granulomatous disease, including TB or non-tuberculous mycobacterial infections, or metastatic malignancy. This is something you don't want to miss and is a classic buzzword. Widened mediastinum, shown here, is concerning for aortic pathology, specifically aortic dissection, in the appropriate clinical context. The question root should say something about sudden, severe, acute onset chest pain radiating to the back. Note the loss of the normal contour of the aortic knob on this chest x-ray. Not all mediastinal widening is aortic dissection, and that is why clinical context is so important. Here is another chest x-ray showing a significantly widened mediastinum due to a large mediastinal mass. This particular chest x-ray is a lymphoma, and it has enlarged the cardiac silhouette as well. This lateral view is not from the same patient, but is included to show how the lateral view can help differentiate the location of a mediastinal mass into anterior, middle, or posterior mediastinum. And just a reminder of the classic 4 T's of anterior mediastinal masses: thymoma, teratoma, thyroid, or terrible lymphoma. And to finish up the mediastinum, I want to include a slide about pneumomediastinum, particularly because the boards like to ask about Borhave syndrome, which is esophageal rupture after prolonged vomiting. This can lead to pneumomediastinum. The most common cause of pneumomediastinum that we as pulmonologists see is rupture of some micro or macroscopic bleb related to underlying lung disease, particularly CF, COPD, IPF, or even asthma, and particularly with increased intrathoracic pressure, such as a severe coughing episode. Other causes of pneumomediastinum include inhaled substances, altitude or pressure changes, such as occur with scuba diving, trauma, or iatrogenic after an esophageal or intrathoracic procedure or surgery. Pneumomediastinum can be identified on chest X-ray as a thin layer of air that outlines mediastinal structures. On this chest X-ray, you can see a thin dark line of extraluminal air, shown here, with the blue arrows that follow the contour of the heart and the mediastinal structures. Related to pneumomediastinum, we will move on to pneumothorax. We all know how to recognize a pneumothorax on chest X-ray. You want to look for a visible pleural line with absent lung markings peripheral to that line. These are two examples. On the left, you can see the pleural line highlighted by blue arrows. The right example shows an apical pneumothorax only, which can sometimes be difficult to spot, but you can clearly see a pleural line within this blue circle with absence of lung markings beyond this. Another chest X-ray finding indicating pneumothorax is something called the deep sulcus sign. This refers to a costophrenic angle that is much deeper and angled than expected. This can sometimes be the only sign of a pneumothorax, but if you look closely on this chest X-ray, you can see the pleural line highlighted by the white arrows, confirming pneumothorax. Tension pneumothorax refers to a small subset of pneumothoraces where air accumulates in the affected hemithorax and can lead to hemodynamic compromise. On chest X-ray, you will see mediastinal shift and lung collapse, generally with a sizable pneumothorax. Clinically, the patient may have hypotension, respiratory distress, and distended neck veins. Tension pneumothorax is a medical emergency and is often due to trauma. However, rupture of a pulmonary bleb can lead to tension physiology. The classic case you will be presented with for spontaneous tension pneumothorax involves a young, healthy athlete, often male, who develops acute dyspnea and chest pain while playing sports. And in this chest X-ray, you can clearly see the large pneumothorax, the collapsed lung, and the tracheal deviation away from the affected side. Moving from pneumothorax onto pleural disease, we will start with pleural effusions. This is the chest X-ray of a young adult patient of mine with rheumatologic disease who presented with left-sided pleuritic chest pain and new effusion. On chest X-ray, pleural effusions can be recognized by blunting of the costophrenic angle, as is shown here on the left, specifically compared to the nice crisp angle seen on the right. And you can see a layering effusion on the lateral with a nice meniscus sign. There is a wide differential for pleural effusions, which we will not get into completely here today. However, sampling of the effusion, particularly for unilateral effusions, is almost always indicated for effusions that are large enough for thoracentesis. One important cause of unilateral effusion is empyema, where thick infected purulent fluid accumulates around the area of pulmonary infection. Because it is parapneumonic, there is often an infiltrate visible on chest X-ray. Because the fluid is so thick and sometimes loculated, it may track along the pleural lining and not follow gravity, and therefore may not have a meniscus sign. There may also be air within the fluid component of an empyema, indicating gas-forming bacteria or bronchopleural fistula. And if you look here, there you can see some air within this empyema. An empyema should always be drained, as antibiotics alone are unlikely to resolve this infection. A common cause of bilateral pleural effusions is congestive heart failure. This is a fairly typical chest X-ray showing bilateral interstitial infiltrate accompanied by bilateral, relatively symmetric effusions with bilateral blunting of the costophrenic angles and the meniscus sign, particularly on the left. It is important to recognize this typical pattern for congestive heart failure. Complete lung whiteout is something that we get called about as pulmonologists frequently. The call will say, "This patient has a large effusion. Can you please come drain it?" But it's very important to know when complete hemithorax whiteout is due to a pleural effusion versus lung collapse or atelectasis. The image on the left shows airway obstruction with complete atelectasis. You can tell this because the trachea is deviated towards the area of whiteout, indicating volume loss. In addition, and it is somewhat hard to see on this chest x-ray, but the ribs on the affected side are closer together. This is in contrast to the image on the right, where the trachea is deviated away from the affected side, and the ribs on the side of the complete whiteout are splayed apart. This indicates a large pleural effusion. Effusions large enough to cause mediastinal shift are often from trauma or malignancy. In some cases, hepatic hydrothorax can also cause effusions this large. Now we will move on to more findings involving the lung fields themselves. We will start with classic cardiogenic pulmonary edema. These two chest x-rays show the classic bat wing perihilar opacities found in acute cardiogenic pulmonary edema. You can see on both of these x-rays that we also do not have clear bilateral costophrenic angles. You can see here, 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 and here, suggesting at least small bilateral effusions. Other findings on chest x-ray that suggest cardiogenic pulmonary edema include sepalization, which is increased prominence of the blood vessels as you move superiorly in the chest. Normally, the blood flow follows gravity, so lower lobe blood vessels appear more prominent on chest x-ray. However, congestive heart failure can cause redistribution towards more upper lobe vasculature. Curly B lines are small interstitial markings that run perpendicular to the pleura and are characteristic of CHF. In addition, people with CHF may have cardiomegaly. You may be able to see the major and minor fissures more clearly if fluid accumulates there. All of these findings are suggestive of cardiogenic pulmonary edema in the right clinical context. In addition to cardiogenic pulmonary edema, we have non-cardiogenic pulmonary edema. Notable etiologies of non-cardiogenic pulmonary edema include ARDS, TRALI, transfusion-related acute lung injury, or TACO, transfusion-associated circulatory overload. The most notable cause of non-cardiogenic pulmonary edema is ARDS. ARDS appears on chest x-ray as symmetric bilateral opacities not fully explained by cardiac dysfunction. On chest x-ray, people with ARDS will often be intubated and thus have a visible endotracheal tube, shown here, visible in this chest x-ray. The question stem should highlight acute onset of symptoms, as this is the hallmark of ARDS. Common causes of ARDS include sepsis, pneumonia, aspiration, pancreatitis, trauma, or inhalational injury. TRALI is another cause of non-cardiogenic pulmonary edema that could show up on the boards. Clinically, TRALI presents as acute respiratory distress and hypoxemia, temporally related to a blood product transfusion. It can occur with whole blood, FFP, platelets, cryoprecipitate, granulocytes, or packed red blood cells. It has been reported after IVIG, but this is rare. You can see in this image a patient who developed TRALI after blood transfusion and had the rapid development of bilateral infiltrates, shown on the right. Treatment is supportive with supplemental oxygen, and it generally resolves over 2 to 4 days. Now we will move on to pneumonia. We will start with the classic lobar pneumonia that generally involves a single lobe of the lung. This presents on chest x-ray as a dense focal consolidation that can have air bronchograms, which is an area of lucency along an airway. The classic organisms that cause lobar pneumonia are strep pneumo, Klebsiella, Legionella, and Staph aureus. When you see a focal pneumonia in the right location, you should also think about aspiration. Aspiration pneumonia presents as dependent infiltrates. The right lower lobe is the most common place for aspiration pneumonia. However, you can aspirate into the upper lobes, particularly if you aspirate while supine, as in what could happen during a surgery. The chest x-ray on the left here shows a right upper lobe pneumonia. You can make out the minor fissure here. The chest x-ray on the right shows a left lower lobe pneumonia. Atypical or interstitial pneumonia presents on chest x-ray as more diffuse infiltrates, generally without dense consolidations. Instead, you see diffuse reticular or patchy infiltrates. When you see this finding with the appropriate clinical symptoms, think about viral etiologies, including flu, COVID, or other viruses in the right host. This particular chest x-ray is from a patient with influenza A pneumonia. These findings can also be caused by Mycoplasma pneumonia or by pneumocystis pneumonia, PJP. Mycoplasma pneumonia is a special situation because it can cause very subtle chest X-ray findings, and the patients can appear overall fairly well. Thus, it is sometimes called walking pneumonia. This chest X-ray shows a patient with mild Mycoplasma pneumonia showing minimal patchy infiltrates. If you get a question on the boards of someone who is overall not acutely ill, but has had low-grade fever and cough for greater than 10 days, with a chest X-ray with only mild abnormalities like this, think about mycoplasma. The board exam likes to quiz on cavitary lesions. There is a very important differential of cavitary lesions that includes TB, lung abscesses, necrotizing pneumonia, fungal disease in the right host, septic emboli, and squamous cell carcinoma, among others. This chest X-ray shows a patient with multiple cavitary lesions, as you can see, shown here, 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 consistent with multiple septic emboli. This patient also has a right IJ central line, shown here, and an endotracheal tube, not surprisingly, suggesting critical illness. This chest X-ray shows a lung abscess in the right upper lobe. There are really no normal anatomic reasons to have a straight horizontal line like this in the chest. If you see a horizontal line, you should be thinking about an air fluid level, such as is found in an abscess. That is the case in this film. Common bacteria that cause necrotizing pneumonia or lung abscesses include Staph aureus, Klebsiella pneumonia, Pseudomonas, and oral anaerobes, among others. An important differential for lung abscess includes squamous cell carcinoma, which can cavitate and very closely resemble a necrotizing abscess. Another important differential includes TB. The boards love to ask questions about TB. They will ask you to differentiate active TB from latent TB. This chest X-ray shows a right upper lobe cavitary lesion and right-sided infiltrate consistent with active TB. Active TB is usually symptomatic, can be infectious, and is usually tuberculin skin test and interferon gamma release assay positive. There can be false negatives, however, so a negative TST or IGRA does not rule out active TB. Sputum and BAL in active TB may be culture positive, and this is diagnostic. Importantly, the chest X-ray will often have an infiltrate, cavity, pleural effusion, lymphadenopathy, or other abnormality. A CT scan can reveal a miliary pattern. Latent TB is generally asymptomatic, not infectious, but also tuberculin skin test and interferon gamma release assay positive. Sputum and BAL will be culture negative, and a chest X-ray may show old upper lobe predominant fibrocavitary disease or may be normal. Now we will move on to chronic lung diseases. In the first one you need to be able to recognize is COPD. COPD with emphysema is recognizable on chest X-ray by hyperinflation paired with flattened diaphragms, a narrow cardiac silhouette, and often loss of soft tissue consistent with pulmonary cachexia. These are two chest X-rays of individuals with COPD, and you can see there are many ribs visible consistent with hyperinflation, and the diaphragms on both of these are flattened. In this chest X-ray on the right, you have a loss of lung markings in the upper lobes, consistent with severe emphysema or bullous lung disease. Severe bullous lung disease can at times be difficult to differentiate from a pneumothorax due to the absence of lung markings. IPF, or idiopathic pulmonary fibrosis, is a common fibrotic interstitial lung disease characterized on chest X-ray by reticular opacities, volume loss, and basilar predominance. It is really better characterized on CT, where there are strict criteria that can separate interstitial disease into probable or possible UIP pattern. CT imaging characteristics of UIP include traction bronchiectasis, honeycombing, intralobular septal thickening, lower lobe predominance, and absence of ground glass. Clinically, IPF presents in older patients with gradually progressive dyspnea and cough. On exam, the classic finding is dry Velcro crackles, particularly in the lower lung fields. This is a chest X-ray from a patient with cystic fibrosis. Cystic fibrosis chest X-rays are characterized by upper lobe predominant bronchiectasis, shown here. They can have spontaneous pneumothoraces. Clinically, for board exams, people with CF will be classically younger, although this is changing as people with CF live much later into adulthood. Recurrent pulmonary exacerbations, colonization with Pseudomonas, Staph aureus, Burkholderia, Cenotrophomonas, and others, and they can present with hemoptysis. And I told you we would talk a little bit more about sarcoid, and that is because the board exam likes to test on the stages of sarcoid, which are radiographically determined with chest x-ray. So stage 1 sarcoid is hilar lymphadenopathy by itself. Stage 2 is lymphadenopathy with infiltrates, which are usually nodular. Stage 3 are parenchymal infiltrates without lymphadenopathy. And stage 4 is fibrotic interstitial lung disease. And really, stage 4 disease is the only stage of sarcoid that is irreversible. I want to talk for a minute about pulmonary embolisms. Pulmonary embolisms are not diagnosed by chest x-ray, and in fact, the chest x-ray for PEs is usually normal, and that's an important thing to keep in mind. But there are a couple findings on chest x-ray that suggest PE, and these are shown here. The first is the Hampton hump, which is a wedge-shaped peripheral infiltrate such as this, and the Westermarck sign here in the right upper lobe, which is decreased markings or oligemia in the area of the PE. The boards like to test the idea of hypoxemia out of proportion to a relatively unimpressive chest x-ray. There are always questions about occupational lung disease on the boards, so I want to spend just a couple minutes on that. The key to getting these questions right will not be in the chest x-ray, but will be in the history. So for silicosis, the history is going to mention sandblasting, mining, quarry work, stone cutting, tunneling, ceramics, or foundry work. Silicosis is associated with an increased risk of tuberculosis, and the classic buzzword is eggshell calcifications of hilar lymph nodes, upper lobe nodules, and fibrosis, and this can lead to progressive massive fibrosis. The second occupational lung disease to know is berylliosis, which I mentioned before. It is found in people who work in aerospace, electronics, or fluorescent light manufacturing, or in the nuclear industry. It resembles sarcoid both radiographically and pathologically, and is sometimes hard to differentiate, but the diagnostic test is a positive beryllium lymphocyte proliferation test. And then coal workers' pneumoconiosis is a lung disease that's found in a coal miner with years underground. The question stem may mention black sputum. It can develop into progressive massive fibrosis and severe disease, and it may mention anthracotic pigment on pathology. This is a chest x-ray of someone with silicosis. It notably has upper lobe predominant sort of mass-like scarring with calcifications and volume loss. The hilar mediastinal lymph node eggshell calcifications that are classic for this disease are better seen on CT. And asbestos-related lung disease gets its own slide because it can present in so many ways. The classic history of someone with asbestos-related lung disease includes a shipyard worker, an insulation worker, someone in construction or demolition, or a pipe fitter. It can have a very long latency period, often decades, before the lung disease shows up. And then smoking synergistically increases the lung cancer risk in these patients. A key clue for the boards is somebody who had exposure during construction or insulation work many, many years earlier, decades earlier. Asbestos-related lung disease is very interesting in that it can present multiple ways, including pleural plaques, interstitial fibrosis, which is true asbestosis, rounded atelectasis, mesothelioma, but notably the people who have asbestos exposure also have an increased risk of lung adenocarcinoma, which is the more common cancer. And then benign asbestos pleural effusion is the last one, known as BAPE. Here's a chest x-ray of two people with asbestos exposure. On the left, we have pleural plaques. And again, you can see these calcified areas along the diaphragm are pleural plaques. And anytime you see just very irregular shaped things in the chest, you want to think about pleural plaques because pleural plaques show up as irregular kind of objects along the pleura in these patients. BAPE, benign asbestos pleural effusion, is really difficult on imaging to differentiate from any other pleural effusion, and the key is going to be in the history. Mesothelioma is a pleural-based malignancy specifically associated with asbestos exposure. This is a chest x-ray of someone with mesothelioma, and you can see pleural opacification that does not follow gravity. You can see it on the posterior of the chest in the lateral view here as well. While mesothelioma is specifically associated with asbestos exposure, non-small cell lung cancer remains the most common lung cancer in people exposed to asbestos. Mesothelioma, fortunately, remains relatively rare. So moving on and wrapping up with chest x-ray buzzwords for the boards. We've mentioned all of these before, but I just want to go over them one more time. The imaging of bat wing edema is suggestive of CHF. Bilateral hilar adenopathy, sarcoid. Hyperinflation and flat diaphragms, emphysema. Cavitary upper lobe lesions, TB, but there is a bigger differential. Small peripheral wedge-shaped opacities, PE. White out hemithorax and tracheal shift away, massive effusion. White out hemithorax and shift toward, atelectasis or airway obstruction. Air fluid level or cavity, a lung abscess. And pneumomediastinum after vomiting, Borje's syndrome. So brief take-home notes. Using a consistent, systematic approach to every chest x-ray reduces the chance of missed findings. The boards do not usually ask for chest x-ray interpretation. Rather, they ask what is the next step, complication, or disease process. You really want to focus on clinical context integration and management implications of what you're seeing in the chest x-ray. You need to be able to recognize the classic chest radiograph patterns commonly tested on the exam, including CHF, COPD, pneumonia, cavitary lesions, pleural disease, and occupational lung diseases. And I just want to sort of mention that many abnormalities that were discussed here really do require CT imaging to clarify in the real world. So the first question, to wrap up this talk, a 67-year-old man is evaluated for progressive shortness of breath and dry cough over 8 months. He worked for 35 years installing insulation in shipyards. He quit smoking 20 years ago after a 25-pack-year history. Temperature is 36.8, blood pressure is 128/74, pulse is 82, and oxygen saturation is 93% on room air. Bibasilar inspiratory crackles are present. The chest x-ray is shown here. Which of the following is the most likely? A, chronic beryllium disease, B, co-workers pneumoconiosis, C, hypersensitivity pneumonitis, D, prior asbestos exposure, or E, silicosis. And we just talked about this one, so it should be pretty straightforward. The answer is prior asbestos exposure. This chest x-ray shows these very kind of irregular patterns, which are pleural plaques. And that's consistent with prior asbestos exposure. Question 2. A 33-year-old woman presents with intermittent fever, night sweats, migratory joint pain, and red painful nodules on her shins. She has no pulmonary symptoms. Shown here is her chest x-ray. Which of the following is true about her disease? The next step in management would be treatment with prednisone 1 mg/kg daily. The next step in management would be bronchoscopy with transbronchial biopsy for diagnosis. Spontaneous resolution is likely, or fevers are an unusual manifestation of this disease. And the answer here is spontaneous resolution is likely. And this chest x-ray shows bilateral hilar lymphadenopathy consistent with sarcoid. And I just want to spend the last minute on a syndrome called Lofgren syndrome. There's always a question on the boards about Lofgren syndrome. They love to ask about this. It is an acute, self-limiting variant of sarcoidosis. It typically affects younger adults. It is characterized by the classic symptoms, including erythema nodosum, which is painful red nodules on the shin, bilateral hilar lymphadenopathy, such as shown in that chest x-ray, polyarthritis, particularly in the ankles, and it's often accompanied by fever. You do not generally need to biopsy if you have this classic presentation because it is so pathognomonic for this syndrome. It typically carries a very favorable prognosis, with most cases resolving spontaneously, and treatment is generally just supportive with NSAIDs. You don't usually need to immunosuppress the patient, but you can use prednisone for very severe symptom management. These are my references. I'd like to especially call out Radiopedia, which is an excellent online repository for many chest x-rays that I showed here. I tried to reference them appropriately on each slide from that database. Thank you.